Welcome to Clinical Unfiltered. Give me your hearts, your minds, your teeth, and we're going to get unfiltered today with Dr. Mark McCawley and, of course, me, Dr. Sausha. Dr. Mark, me and Mark go back. We go way back to resident. I told you guys I was going to get some knuckleheads for my residency, and I found the perfect one. Now, Mark, I got to tell you, so I always thought it was funny. So today, I'm just going to jump off and let you know, we're going to be talking about lasers, specifically one type of laser. But in residency, Mark would randomly disappear at conferences, and I'd be like, "Yo, what are you doing?" He's like, "Oh, I got to give a talk or something." I'm like, "What the hell? Why are you talking?"
Wait, you have to at these conferences? You're in residency?
Yeah, I was like, "That's so weird." I was like, "Yeah," and lo and behold, and as I start getting through residency, meet his dad, and then find out that this guy who owns ferrets. Do you still have your ferrets?
No, not anymore. Not anymore. They don't live that long, but
yeah, I was about to say. Sorry, soft subject. Yeah. But anyways, he owned ferrets, and I was what?
Fantastic pets. And
him lecturing, that just didn't all add up to me. Anyways, find out you and your dad wrote some freaking papers on the specific laser, an Nd:YAG laser, correct? The papers were mainly on the Nd:YAG laser.
Yeah.
So your journey into Nd:YAG lasers started, what, circa 2012?
When I was about, 7 years old.
Oh, gotcha. Is that how they did your circumcision?
I mean, it's one of those things. I literally did grow up in the office, in the practice. So I saw a dental laser when I was probably 5 years old. So, because my dad got into it real early. He actually got the first periodontal laser, dental laser in general, Nd:YAG laser in the country. So that was back in 1990.
So that was considered the first periodontal laser, the Nd:YAG laser?
Before that, you had CO2 lasers and stuff like that, but honestly, they weren't good for treating periodontitis, treating perio disease. So you couldn't really, you could use them for bone reduction and some of them you can cut on teeth with, but it's not really a great perio laser.
Now I feel like now they're trying to market, but you're saying back then they didn't. Did they even market it as a periodontal laser?
No, back then, my dad got into it super early, so he kind of heard some studies coming out of Canada, and I don't even know if there were studies. I think he found it in a dental economics article,
okay.
Those things that they just have throwaway things they send to everybody who will I
just did one of those, by the way.
Yeah, so I'm sure you guys market
super profound,
great,
super profound,
mind blowing. No, but he saw it there and he was like, wait a minute, it's that sounds pretty cool. He's like, what kills bacteria better than heat and light? And he was like, all right, I gotta try this out. So he literally imported it from Canada before it was FDA approved or anything. He started using it, and it worked.
I knew I liked your dad.
So yeah, dude, guy's completely cutting edge. He tries to be
met a smuggler in a back lot to get his
smuggling lasers in through Detroit. Yeah, no, he ended up getting that, and then it just kind of snowballed from there. Initially there was a lot of backlash against it too, because lasers in dentistry, people thought he was crazy. They're like, lasers? You're gonna burn someone's mandible off. They thought it was just this most crazy thing.
Oh wow, interesting.
But yeah.
But do you think that stigma came from maybe more of a CO2 laser or was that not even around also?
I think, they started to be around toward that time. This was early 90s type of thing. So you started to see CO2, some erbiums are starting to show up here and there. But by the time he got it in 1990, and nobody had any studies on it really. So he basically, because there was so much backlash, he was actually the Florida Association of Periodontics. I think it was Florida Society of Periodontics back in the day. He was the president, and they actually voted to try to impeach him because they were like, "You're doing this unethical treatment." So they tried to impeach him. Luckily, he was able to back everything up. He's like, "All right, no, this is what's going on. This is not crazy." There's some backlash to that thing. But, the traditionalists, I understand what's been working for years works for them, but there may be a better way out there. So actually in 92, he did a study that actually showed that he was able to disinfect even like the calculus, they did like SEM, like scanning electron microscope slides and stuff. And he was able to actually show that you could disinfect calculus with it. So he was like, all right, that's super cool. Like you can disinfect calculus, you disinfect the pockets, like that's cool. So that's kind of how we got started. So you say, you know, where did I get started with lasers? I mean, literally at the beginning of lasers in dentistry and periodontics. That's where I got started. I was, you know, working in the office when all that was kind of going down as a kid even.
So what was the first study you kind of got wrapped up in?
I mean, I got wrapped up. Because they started doing like multi-center studies with Millennium, the big, you know, the current indie YAG producer.
Yeah, we're not sponsored by anyone. So
no. I know. Trust me, no.
Yeah, we can mention anyone's name.
I can mention anybody, but no, I mean, that's the one we work with because it seems like it's got the most variability to it. Like I love messing with the settings. So the Millennium, at least in my hands, works the best. I know there's like a Lightwalker out there and it does basically the same thing at a lower price point. But if you're really getting into the weeds, like it's really helpful to have that variability of the settings. Cause like you see, like I don't keep the settings the same for every single case. I'm constantly tweaking with things. Even if I've got like a different part of the arch, I'll mess with the settings and move around and I'll do that. So like, you know, the variability really helps as you kind of grow with the system.
You kind of said that to me too one time. You're like, Sausha, you like fiddling and messing with stuff, and you're gonna like the laser for that reason. And you know, you go to the course, they kind of teach you. And nowadays, you know, mostly everything has a preset button. It's like, what procedure you're doing, here's the button. But in realistic nature, I mean, tissue is just not, you know, homogeneous like that. You're not bumping into every single pocket being super inflamed or, you know, every type of biotype, every type of pigmentation. It's different. And I've run into situations where I'm like, man, I'm hitting the tissue, I'm not getting much of a response, or I'm hitting the tissue and I'm just blowing through it too fast. You know, like I'm the gut tissue's gone. I got to tone it down a bit versus areas where I'm feeling, and I feel like the ability to play with that. The nice thing is with the training, you kind of get where like the standard area. It's like this is like the general setting, and if you uptick this setting, you'll start, you know, frying the tissue more. If you downtick this setting, you won't. You'll kind of, you know, you're changing the pulse rate and all those things, and it'll affect how you're actually. What kind of energy you're applying to the tissue. Let me ask you this. So I'll go back to that study. So that first study, that multi-center study.
Yeah. So they did a multi-center study, and I honestly, when they started doing it, I was in college. So like I helped out a little bit, but I didn't get on the paper really. I was just kind of helping out in the ancillary stuff. But the one that really got me like into it was when I was in like, it was like tail end of dental school and the beginning of residency for me, my peri-residency. I ended up and my dad was like, hey, you know what? There's no study out there that shows that you can completely disinfect the pocket using anything. And he's like, I think we can do it with the laser. He's like, from what I've seen, I think we can do it with the laser. So he's like, let's do a study on it. And I was like, all right, let's do it. So you know, I wasn't certified at that time, but I kind of helped out. I did all the data and stuff for that one, so I was really kind of involved in the in all that jazz there. So
disinfector, you're talking about almost like sterilizing a gum pocket.
I mean, you can't, I mean, disinfection and sterilization. You know, it's hard to prove complete sterilization, but disinfection you can basically prove if you culture it before and then you treat it and then you culture it at the end. That's, you know, if there's nothing there, you can reasonably claim that it's been disinfected.
And that was what the study was showing was.
Yeah, that's what our study showed. So that was back in like, I mean, shoot, we did the data back in like 2012, probably. We didn't get it published. I think we presented to the American Academy of Dental Research in like 2014. That was again when I was in residency. And then we ended up getting it like, it finally got approved by a journal because we got, well, again, there's a lot of backlash against lasers. So we finally got it in a peer-reviewed journal in like 2018. So it took us like 6 years to get that thing published. We got like input from a bunch of researchers and we kind of wrote it up just the way they wanted it to. Because, you know, it's tough to write a good research paper that like ticks all the boxes that the peer review process really likes to read.
In residency, you're kind of trained to like pick apart research articles. And I think that's like probably one of the best. Not even so much knowing the research articles, and I actually like picked up on that quick, which is why I don't know a lot of the research articles by heart. I just know how to read a new one.
Search the entire time here. Come on, man.
I was always so bad at that, and no one ever picked up on it, which was great. But I learned how to pick it apart. I took out the points, the bottom lines, but I knew how to like pick it apart. I was like, I could find a flaw in a new article. And the articles that I feel like we would try to like backlash with the lasers. And I felt like, hey, it produces regeneration. Like the NDAG will produce periodontal regeneration.
Histology studies back in like, I think 2007 and 2011 or something like that ended up, and they actually did histologic blocks where they actually basically they took hopeless teeth that they were going to extract anyway. And then they were like, hey, how about we do some histology on these? So they took them, they extracted them, they took out a little bit of bone with it too. So they were able to actually show that there was new bone compared to where it was before, because they made a little notch on it, and if the bone grew over the notch,
pre-treatment they would notch the tooth.
Yeah, they notch
it with a laser
because they're like, all right, that's where basically the base of the pocket is, the base of the bone, and if they got attachment over that notch, then they were like, okay, we got new attachment. Did we get new bone? So they were able to see that, and they actually found like I think a majority of the cases they found there was actually new bone growth, and pretty much all of them got like new connective tissue, cementum, and
I think basically like selling points.
So
histology where it's
like hopeless teeth,
attachments growing into the notch.
Yeah. So you can see it like growing into the notch. So you're like, all right, I know that's new because like literally you'd burr it out. So
the see, this is the thing. I did an episode with another doctor not too long ago about lasers, and I openly mentioned, I'm very open about this, that I was a laser like racist.
Oh yeah, you would like rip on me and be like, oh, lasers this, lasers that. I was like, hey man, whatever. I was like, you should get one. I was like, I'm still saying you should get one.
Well, this is the thing, which I find ironic because I love technology and I love new tools and I love like finding a better way. And I was like, what? In one point, and one day, I was like looking at a mirror and like, metaphorically, and like, dude, this laser actually embodies a lot of your potential values. Learn about it before you poo-poo on it. And then I looked into it, and then once I physically got it, and my like whole practice changed, and now.
No, I mean it completely just like changes the focus and the scope of your practice. You're like, oh my god, I can actually treat perio. Where before you're just like, all right, let's scale and root plane, or let's do some osseous and grind on it. You're like, all right, maybe that's not the best thing.
Before I would see patients, I'd see a lot of consults who needed osseous. Okay, so GPs do the SRP, we do the SRP. Someone does the SRP, and I'm looking at them, and I'm like, all right, we're gonna need to like get in there. And I would try to downsell the fact that I'm about to put an incision in the gum tissue as much as I possibly could. I mean, I really was like, we're going to access the underneath the gum tissue. We're going to, and then have full vision and be able to clean I would never say like, we're going to cut the gums. I never say that. You got a
patient, you're like, well, how do you access it? You're like,
they can read that bullshit. Exactly.
Yeah. You're like,
the bullshit. They do.
That doesn't sound as appetizing.
They do it all the time. And you know what? I would go to these patients. They would do it. They would do like a maintenance visit. I'm like, hey, the pockets still look really crappy. And
it's like we need to.
Like, I just don't want you to cut.
Do this, yeah. No,
I don't want you to cut. I don't want to have to pay for bone graft because bone grafts aren't cheap either.
Yeah,
all that was like.
Oh yeah. No, I mean, there's just barrier on top of barrier for like people getting treatment that need treatment. Mm-hmm. And I mean, it's night and day, man. You can get such a better result for a 10th the amount of discomfort that you get. I mean, I remember in residency, because we didn't have lasers in residency, they were kind of like a little bit anti-laser a little bit, but we'd end up doing like a couple quadrants on them, like maybe a half a mouth, and then the patients wouldn't want to come back for the other half a mouth because they were like, man, that hurt too much. They're like, I don't want to do it again.
Yep. You do a quadrant and they're gone.
I can't say I blame them too much because that beats you up.
The amount of perio I guess I left in limbo because I wasn't using the laser was insane.
Oh yeah.
My ability to close cases. I mean, for everyone who's listening, who's like still cares about the marketing side of things, the ability to close cases was so down. Once I got the laser and started to implement it, and of course the conversations are easier. Like, no, I'm not going to cut. I'm using this technology. You usually throw out the word of laser to a patient. Yeah. They like that. They like that stuff. It's just like the 3D printers and intraoral scanners. It's just one of those technologies they like to hear that's being.
Yeah, they're like, oh, that's like, it's like AI. So you say AI and anything, and everybody's
yeah. The AI lasers.
Yeah, it's
AI lasers. We're doing AI lasers, guys.
No, I mean, it's one of those things where, like, okay, like this is fairly cutting edge here, and you're going to get a better result because, I mean, shoot, use lasers in pretty much any other field of medicine, and it's something where you get good results with it. So
the treatment plan acceptance like went up so much, and I sat back. I sat back and I looked, and I was like, you know what? The amount more of perio that I've actually been able to treat because I'm using a laser is significant. I mean, we're talking like probably 5 times more than I was prior to having the laser.
Yeah. So
now,
before
as
the
periodontist,
laser, like an implantologist, basically, like you just take out place implants.
I did do a lot of osseous, but not as much, because it would take longer too.
Periodontologists have kind of gone down that road because, again, without the laser, like it's a whole lot easier to take out a tooth and place an implant as opposed to save it. If you've got the laser, and you're like, all right, now it kind of tips the scale where you're like,
for sure,
okay, this is like way better, way more cost effective for the patient, and it's just something that's going to work out a whole lot better for them too.
They can keep the teeth. That's the thing. There are a lot of times where there's a really advanced perio cases where if you're going to start flapping gum tissue open to access, you're like, I've got nothing left. Like these teeth are just going to flop out as I flap. Those scenarios have actually, like, I've got one more shot for you. It's the laser. We're going to try it. It's either that or you go to like dentures at that point, and I have so many cases that we're in those scenarios, like almost near hopeless dentition who now are still maybe 5 years out, still in their dentition, rocking them, still enjoying them, watching us. What's funny? If you go back 5 years, doing full arch implant dentistry was much more difficult when it was analog. And now it's easier and more cost effective. I can do the same treatment cheaper for them if the day comes that we have to. God knows, man, if I can keep them for another 5 more years and we're regrowing damn teeth.
It's key. I was going to say, like, who knows what's going to happen? That the next stage, we're just going to be regrowing teeth. But
you see the evolution I've had, Mark? It's like I used to be like, screw your lasers, and now I'm like, yes, man, let's do this.
Honestly, I feel like I might have been the catalyst for you to actually get the laser, because it was at that meeting where I was like, dude, just get the thing. You were like, should I get it? Should I not? I was like, just get the laser. I was like, you're stupid not to. I was like, do it. It's going to be the best thing you ever did in your practice. And
I did. It did, and it has been. I will tell you.
You did. You signed up. You're like, I hope it works. I'm spending all this money. I was like, it's going to work. I was like, just do it.
Well, that's when I was actually, I think I said that in another episode too, is that when these costs go so high up for new technology, you will actually create an excuse not to get it. You're like, intraoral scanners, they're not accurate.
No,
we don't need intraoral scanners. We can do it the old way. They're not accurate enough. Well, they are now. And it's the same thing with the laser. It was like, it's such an expensive tool. Traditional osseous is better than laser. I don't need it. Of course
it's better.
Yeah.
But
like for who?
For a little blade and then some sutures. Like that's your disposables with a traditional osseous. You don't have to worry about this $100,000 plus laser sitting over there collecting dust. You got to use the darn thing. I mean, trust me, we use that thing every single day. That thing is getting miles on.
And that's the thing is I was telling you, when any CE you're doing any product, you buy it for an intention. You got to intentionally buy it to then use it.
You're like, I'm interested in this case. Yes.
We're mainly focusing on kind of like osseous and periodontal surgery based uses of it. And this is the thing, when I went to the course, I know you could attest to this. I felt like most of the people there are general dentists actually taking the course to be able to provide like some kind of advance. And I don't hate on that because I'm like, you know what? In the end, still more perio is getting treated. Trust me, there's plenty of perio to go around that's still going to be treated by. It doesn't have to be a periodontist. It's not as technique sensitive per se as a traditional osseous surgery. And this is the thing. I think a lot of people think like, especially as periodontists, you're going to look at the osseous surgery where you open up the gum tissues. Of course, you got great visual access. You can apply a lot of tools to, remove the bacteria. But there's a lot of research that actually supports that even after full flap osseous, you're still going to leave some stuff behind because I've been there. There's spots that are just damn near impossible to see. Like the back end of a furcation on a number 14 or a 15. It's hard. It's hard to see in between the teeth in those areas. And I still, even when I have flapped or done a distal wedge, I still use my laser. I feel like I got to get in there and kill stuff. I still feel like you have to at some point get some kind of instrumentation to disinfect because you can't truly visually see.
Can't truly visualize it. And honestly, that kind of ties back to the 92 study that my dad did. You can actually desiccate and basically disinfect calculus. And I've seen some cases where there's like a little piece of calculus real far apical and it's missed. And then I think it might have been one of the Lanap ones where it might have been like in one of the trainings, but somebody was lecturing and I was like, wait a minute, there's calculus there. And you actually saw the bone grow around and above the calculus. I was like, it's incredible. Like if you disinfect that calculus, it almost, you don't really have to remove it to the same degree that, I mean, obviously you want to try to get as much as possible, but no matter what, you're going to leave little pieces here and there, little microscopic pieces. So if you disinfect it, then the body's like, it doesn't care that much. And you end up getting some great results regardless.
Like a disinfected burnished piece of calculus, like it's probably really similar in ultrastructure to like cementum and dentin.
Cementum at that point, it's cementum, a little bit of bone, like, it's probably not that different and it just grows over the top as long as you get rid of all that like lipopolysaccharide and all the endotoxin and stuff, you're good.
And this is the thing too, is after the fact. I know a lot of people who are like, still osseous reduces the pocket so much more. But yeah, because you're like chopping away a lot of bone in the process. And I've seen it's like, I've seen laser cases relapse. I've seen osseous cases where I've opened up and done bone reduction relapse. And what makes me fearful is that I have sped up the process.
Yeah, I was like, you removed attachment instead of actually gained attachment. And it's funny you mentioned that because I had a patient who I treated in residency. And, it's one of those, you had a ton of pockets, cut them away, cleaned them up as best as you possibly could. And then he relapsed and he found me after I had graduated and I treated him with the laser and we got him healthy. So that's the thing. The osseous doesn't disinfect. So that's the benefit of the laser. And honestly, you were talking about relapse and stuff. You got to get a phase contrast microscope. That's the next thing you got to get is a phase contrast microscope.
Yeah. So talk about that. Talk about that modality because I find that very unique in your office. Yeah.
So I mean,
walk me through that patient experience.
Doing it. I mean, I my dad, he's been literally preaching using the phase contrast microscope for the last like 30, 40 years at this point.
This is great.
So there's a lot of resistance to using it because it's a little bit technique sensitive. You got to know what you're doing. But as far as like being able to diagnose and follow up these patients, like, you mentioned relapse. You can catch relapse before it happens if you've got a phase contrast microscope. And that's kind of like, what we really honed in on was the microbiology. And, it kind of makes sense with all this laser stuff and all this disinfections talk. But you got to make sure that they can maintain that disinfection. That's why, we've got laser cases that have been stable for 10, 15 years, 20 years. I mean, there's patients that came in that have been like, hey, your dad saved my teeth, 20 years ago. And it's like everything, he's got 3-2-3s, like no pocketing. Everything looks fantastic because we're able to maintain them. And that's where the phase contrast microscope comes into play because you can actually view their bacteria live. You basically take a sample of the bacteria, put it on a little slide, put a little saliva in there, mix it up, smash it down, and you've got a microscope where you actually project it to the TV in the operatory with the patient. So the patient gets to see all this.
Out of curiosity, is a microscope in the operatory or is it?
No, well, we've actually got two of them now. One of them is down the hall, and we've got it like wired into all of the monitors. So we've got our monitors, we've got computer screens on them and stuff. And if you change the input, you can view the microscope. So that way they get to see. If you've got basically dots and lines that sit there and they just stare at you and they do absolutely nothing, that is fantastic. That is exactly what I want to see. All my recall patients that have that, I'm like, keep doing what you're doing great. If all of a sudden I start seeing some spirochetes, some modal bacteria bouncing back, God help them if they start getting an amoeba or like trichomonads or something, then I'm like, all right, we something's going wrong. Like we need to nip this in the bud because we don't want to have to do laser again. My goal is to do the laser and then get them so they can actually maintain it themselves. And then we're able to basically, keep them for years and years.
I know you guys do it as the initial visit. When they're a new patient, you do the phase contrast. I remember your dad talking to us about that. He would take a sample of their and he's like, hey, look at all this like wiggly stuff moving. Because spirochetes you can actually see physically moving. I remember him showing us that video. It's gross. It's gross looking.
You got millions of those in your gums. like that's why they're red and bleedy. They're not red and bleedy because I just took a probe and lightly touched them there. No, if you do that to a healthy pocket, there's going to be no bleeding. You do that to a disease pocket, you're going to get tons of bleeding, pus, all sorts of stuff. So the bacteria is what actually causes the infection.
And you show them the bacteria, and you're like, this is it.
This is it. And to be able to actually show someone the cause of the disease when, I've had people that have been like, oh, I got treated, like this is my third or fourth time getting treated. And they're like, why did no one ever show me this before? It's like, because nobody looked. It's like, if you look for this sort of thing, you can actually see it. And if you see it and you know how to treat it, you can actually get rid of it and you can basically keep them stable. So, I mean, that's kind of my office's claim to fame, is being able to not only treat them the most effective way possible and also maintain them, because every single maintenance appointment, we take a sample. And if they're good,
every
maintenance, all of my hygienists are pros at taking samples.
Now, are you doing rotational cleanings like other periodontists where they clean in their
so normally, after the active phase of treatment's over, after like the first 9 months or so, because for the first 9 months after the NAP, the laser disinfection,
them.
We follow up them pretty rigorously. We see them like every 2 months or so. So we're following up. We're beating oral hygiene into their heads. We want to make sure that they know exactly how to keep it gone for the long haul. And if they do what we tell them to, they're going to have, a great response. And then we follow up with them. And, we see them every 6 months or so. So we alternate. We like every 3 month recalls. So 3 months dentist, 3 months periodontist. So that way we can make sure they don't fall off the wagon, so to speak.
But at those maintenances, you're not using the laser.
No. We're not using the laser at the maintenance. It's just basically we do cleanings. If they're starting to get some issues, we may use some antiseptics like chlorhexidine, betadine, like periodontal, which is like kind of it's a pretty good antiseptic there that kind of for spot areas.
And let me ask you this: if they are persistently having a lot of bacteria show up on your phased contrast on your microscope, do you then say, hey, we got to do this again? Or do you ever have to retreat because of or is it just correlating with them progressing anyways?
Honestly, if I see the pathogens building up and then, normally it's hygiene, it's oral hygiene, they stop doing something that we recommended. And there's certain things that we can do to kind of jumpstart them and get them back, back on the program there.
Which is a big problem in periodontal patients, by the way. Everyone who sends to a periodontist who we can obviously do a great job of setting their bacteria down to as low as possible. It's just, it comes back again. It's like I have a maid cleaning my house every 2 weeks, and it looks like shit in a week.
That's the thing. It's a lifestyle change too. I mean, because I have a very candid conversation with these patients, because I tell them that. I'm like, hey, listen, I can get rid of the infection. I can get rid of this bacteria. I know this, but it's your job to make sure it stays gone. And it's like, I will give you all the tools and training necessary so you know exactly what to do. You just got to do it. And it's like, trust me, when they leave my office, they are an absolute pro at keeping their gums clean. But it's just the motivation.
Are you doing your oral hygiene instructions, or you're having your hygienist do them?
I'm doing kind of the initial ones. I'll kind of give them a rough overview, but my hygienist will really sit down with them and show them exactly how to do every step along the line there. So that way they know what's going on. And honestly, that's probably one of the best reasons that we follow up with them so rigorously for the first 9 months. It's as much, giving them cleanings and things like that as it is actually oral hygiene instructions to make sure that they're still doing what I want them to do, because honestly, that's kind of what makes or break these cases for the long haul here. Great. Oh, I got a great result after 6 months. My goal is to have a great result after 5, 10, 15 years. 6 months, I'm like, all right, whatever. I want to make sure that these patients can maintain it for the long haul. And that's kind of what we've geared our practice around, because it's frustrating for patients to have to undergo that sort of thing, repeatedly. Nobody wants to go through perio surgery again. No, that's a nightmare. So, if you can maintain it, then you don't need to.
I just saw a patient last week. I did osseous surgery first year I got out into the real world. So it would have been 7, 8 years ago. And I saw them, they found me again. and they were like, hey, like I fell off the wagon again, but I went to go get a cleaning and they wouldn't clean my teeth again. And I looked at him, I was like, all right. And he's like, man, like came back to me. He was open to like getting like ripped open again with the osseous surgery.
The osseous again. I mean, that is a rare breed right there. That you don't see too much of that.
But when I told him, I was like, hey, we're going to do the laser instead. Man, the amount of sheer joy this guy had.
Probably just like smiling ear to ear. Yeah.
Beautiful, because he went through a whole mouth of osseous and a whole mouth of laser treatment, Lanap essentially. And I mean, it's for him, he's like, it's night and day. It's like it's the experience was so much more different. And this is the thing. Sometimes I feel like the experience of osseous can sometimes either rope people in or freak them the hell out and disappear. Like I said, you do one quadrant of osseous and you can see someone disappear. The maintenance protocol is interesting though. The microscope is something I definitely.
Microscope. See, this is the next piece of technology that I'm going to twist your arm to get.
No,
the laser works out. The microscope's going to work out for you too. You just got to train your staff to use it.
Listeners, you got to understand. Dr. Mark McCawley and his dad are probably one of the few. There's not that many true periodontists out there who are just like out there actually treating perio in their periodontal offices. Most of us have become implant doctors. And you know what? The amount of perio that exists in your offices compared to the amount of implants exist, the perio is definitely more prevalent in a lot more offices than most people would admit. There's 5-6 millimeter pockets that are being maintained.
Yeah, so they turn into an 8 or a 9, and then they're like, oh, now we got to take the tooth out.
And we see it all the time. And I feel like having the ability to like easily treat perio is something that I really think a lot of people should look into. Because honestly, utilizing a laser to treat periodontal disease, at least with the Lanap protocol, utilizing the Nd:YAG laser is really straightforward. The other thing is that I've heard, I mean, there's other lasers on the market. The nice thing about the Nd:YAG is that I've noticed is that it is, especially for periodontal disease, a lot easier to treat without too much collateral damage. Like the other lasers, I had a friend on a podcast, and he was like, he's done articles too, and he was saying, he's like, diode wavelength actually comes pretty close to an Nd:YAG wavelength. I was like, all right, interesting. So like, are you saying that you could do everything you could do with the Nd:YAG, you could do it on a Lanap, on a diode laser? He was saying you could do both on the same. And I was like, oh, this is hot. This is interesting. Can you counter that? Can you counter that statement?
I can counter the statement because it's just the pulse widths and the duration that it's on are completely different. And I mean, the design of it is completely different too. So the wavelengths, they're close, but the thing about the Nd:YAG that's kind of basically its claim to fame is it's very selective. And that's what the CO2, the erbium YAG, like, you know, each of them have their own little niche where, you know, you can do certain things with it. The Nd:YAG is beautiful for soft tissue because what it does is it removes the diseased epithelium without damaging the underlying connective tissue. It basically peels it away on those little REIT pegs, those little REIT ridges right there, right where the melanocytes attach. It basically hits the melanocytes, those peel off, leaves the connective tissue, and then the connective tissue is stimulated, so it just grows up. So you remove all of the pocket, and then you end up stimulating the connective tissue and then the bone underneath. And that's why you actually get the results that you get right there, because it's very selective. You know, that's what people were afraid of back in the 90s. They were like, oh, the laser is just going to burn everything up. Well, not with the Nd:YAG, the specific wavelength. And the earlier ones, the one that my dad got back in 1990, that one you got to be very careful with because, again, they didn't fine tune the pulse widths and the duration and things like that. Nowadays, we actually have the lasers that are a lot better. They can actually basically specifically target what they need to target. The amount of tissue you want to remove, you've got it in the settings right there. Different settings will remove a certain amount of tissue right there. So it's something where you just remove just the thinnest little layer of epithelium. So that way you're not going to get all, you know, like after osseous, when you cut everything away, you get all these super long horse teeth. No, that doesn't happen because you're not really removing tissue. You're just removing the pocket lining right there. And that's where all the bacteria go in. And also the benefit of this wavelength is it's the same thing, kind of like it's like infrared. So if you put a red laser up against your finger, you'll be able to see it on the other side. Same thing happens with this laser. So you don't actually even have to touch the bacteria to get the effect. It transmits through the tissue, through into the connective tissue, onto the bone. So all the bacteria that are tissue invasive, it eliminates those too. So that's kind of the why the Indy YAG works so well. And the diode, they're trying to get the pulse widths and things like that, but there's still, you end up just damaging the tissue way, way, way more with the diode. So, the diode, if you want to cut tissue, there's nothing better to actually like cut tissue with than a diode, but it's an indiscriminate cutting tissue. It's not a, hey, this is exactly what I only want to remove just the teeniest little bit and it'll just remove it like that. No, that's when you want to get an Indy YAG laser. So
what I've noticed is like the specificity, like being able to use that laser for periodontal disease and pathogen fighting is superior. Whereas like, you're using like a silencer or sniper with the Indy YAG versus using like a bazooka.
Yeah. The diode is basically a bazooka. And the thing is, like, I think with the diode, like it still leaves bugs behind because the energies that you have to put out, you either burn everything or you don't use enough energy. Like you can't really get that happy medium right there with the diode.
So for safety reasons, it's definitely a plus to have a laser more specific to that role right there. Now, if you want to cut a frenum.
Oh yeah, no. The frenum, like they've got a frenectomy setting on the Indy YAG, but if you want to sit there for like 20 minutes trying to cut a frenum, you go right ahead with that. But a diode just gonna be like zip. So again, if you want to cut connective tissue, then the diode is going to be your thing. But if you're trying to get regeneration, you do not want to cut connective tissue. You want to stimulate the connective tissue and basically get it to regenerate instead of just butchering it and just burning it all.
If you were to experience having an Indy YAG versus a diode, I think that's one of the first things you'll notice. You'll run it, you can point it right at healthy tissue, but you'll be pointing a long time before you see any change. Mm-hmm. Whereas like diseased tissue really just kind of burns through.
Oh, it just peels it away.
It'll peel that. Yeah. Inflamed tissue just has
a lot of it has to do with the pigment of the tissue too. So the more red it is, like that's why they say don't do scaling and root planing with this. Just do the laser because you want that pocket epithelium to be red and inflamed. You actually get a better result. It peels it away. You get better regeneration there. So I love seeing a red inflamed pocket because I know that laser is just going to basically just peel it out. It's going to get rid of all the infection and you're going to get a great result there.
Like that's what I'm saying. I feel like it just makes so much sense if you're trying to actually help your periodontal patients. Like, yes, you could do SRPs, but this isn't that much harder of a technique to pick up. So it's like if you're looking for a good ROI on some, because you get there's an upsell there, and for the betterment of a patient too. So you're gonna have a better periodontal therapy, and you can do slightly more advanced periodontal therapy if you've got some tool like an Indy YAG laser within the office. If you want to take it the extra mile, the microscope. And the maintenance.
The microscope, that's if you really want to treat perio and like hone in on it and just live it every day like I do, then that microscope is huge. We do that. Anything that looks a little weird, I'll culture too. So we got a bunch of cultures. We're actually working with another company to try to fine tune their culturing technique. It's a new DNA one. They actually test for viruses too, which is super cool. So for the first time, we're actually able to like hone in and treat specific viruses in the pocket too, because that's another one of those things where it's like throwing gasoline on the fire. You end up getting a much worse, much more advanced perio case if you got viruses in the pocket, and we treat those as well.
Right. We've always been fighting the bacterial problem, but yeah, I remember in residency we kept growing the idea of like funguses, parasites.
You didn't have the microscope or culture because there's some of these cases you see just they've got tons and tons of yeast like fungus growing in their mouth. And again, if you treat it with like an antibiotic, you're not going to get the results. You gotta know what you're going up against. And there's a lot of atypical periodontitis cases out there, and that's kind of our bread and butter. Where there's patients that come in, they're like they've either been treated before or they're scared to get treated, and then they come in. Or I've had some patients come in where same thing like what you said, They're like, yeah, this is a second opinion. The first doctor said I needed to take all my teeth out. And I look at him, I'm like, no, I was like, I can save these. So, I mean, that's kind of, honestly, those are the most rewarding cases when I'm able to turn a case that was like legitimately would have been a denture.
That was my guy who had osseous 5 years ago. That he came in, he was told, he's like, no, we can't clean, we can take them out. And I was like, no, dude, I'm gonna laser these again, and you're gonna be fine. And it's easier to get a patient to consider doing another laser therapy 5 years down the road to keep the ball rolling if you have to. And for the cases that I've noticed that have relapsed, it's always due to hygiene. It's like I've done everything I can. They're just not wanting to keep it clean afterwards. And there's like, it doesn't matter who it is.
We do a deep dive into like nutrition and stuff too. So like, and some systemic factors, even medications, they'll kind of throw them off too, especially like, steroids or immune suppressants, weird things like that can throw them off. Like even some antidepressants will kind of mess with the way the body heals too. So there's all sorts of different things that, I mean, that's the thing. Like, very thankful I had my dad to kind of basically like give me this baseline, and then I've just taken it. I've just kind of just dug deeper and deeper and deeper, and then now we're just like so deep into the perio, and it's cool, man. I mean, honestly, that's what keeps me going to work every day.
When it comes to surgical osseous versus the laser-based periodontal therapy utilizing the Nd:YAG, it to me, it's a no-brainer. In my mouth, it's Nd:YAG.
Oh yeah, no, Nd:YAG every day.
We're gonna expand on like other uses in another episode, like the outside the periodontal therapy uses in a second. But if people wanted to dive a little bit deeper and understand using lasers for periodontal therapy, what resource would you tell them to go to?
Lasers for periodontal therapy. The thing is, I don't know. There's a lot of this has kind of been self-taught and just kind of just friends of my dad that have been like basically they're again the pioneers of kind of the laser movement, the laser techniques here.
Where does someone new, like they listen to the podcast, like, man, damn, I need to get a laser to try periodontal therapy. Where do they go? Companies,
honestly, the companies have, they've got pretty good stuff. The Millennium's starting to get some more data behind them too now. You can check out the Lightwalker too if you want to. I mean, I'm definitely preferential to the Millennium because it's more of an advanced laser. It's for the people that actually, do this day in, day out.
Go to the companies. Gotcha. Yeah. You're right. I'm trying to think who actually teaches about the topics unless you have a laser. So this is one of those things where you have to go to the companies to like learn more about using the laser because you need to have one to do it.
I lectured to the Florida Dental Association meeting like a month ago, and it was the only laser actual, only laser lecture they had there. So that's how you got to learn. You got to just find people and then, try to figure it out.
Mark, you just got to get one. You got to get one. If you want to, you just got to get one. Then you'll know.
That's what
I did. I didn't learn anything about it till I bought it.
I literally, you kept saying like, oh, should I really get it? What about this or what about that? I was like, listen, man, it's like one of those weird things where you just kind of take a leap and then trust me, it's going to work out. I mean, again, I know you're talking about the GPs getting it, like general dentists. And honestly, if you've got that kind of volume or you've got like multi-practices, things like that, I think it's going to be a good ROI. I've seen some GP practices that aren't like super busy get it, and they can't make it work because they just don't have the patient flow for it. So you've got to make sure you've got the patient flow to warrant having, $100,000 or $120,000 investment into a laser. And then, days out of the office, getting trained and things like that. So you got to make sure that your office can sustain this sort of thing. It's not like SRP where you can just, delegate it to a hygienist or something. This is something where you need to do, and you need to make sure that you've got the volume to warrant that. Like as a periodontist, like it's a no-brainer. It's the best treatment modality out there by a mile. But for a general dentist, it's, unless you've got like a lot of patient volume. And I know you probably see it initially, but after you burn through those initial patients that you've kind of been stockpiling, like the 5s and 6s that you're like, I don't really want to refer to a periodontist yet. And then as soon as you burn through those, unless you've got a constant new patient flow, then that you're going to basically use it for the first year and a half. And then after that, it's going to collect dust. So like you want to make sure that you've got the patient volume for that sort of thing.
Right. You have to create your system around it. That's a good point. I mean, that goes with any technology. I feel like you got to get ready to kind of like either uptick your marketing, watch your new patient flow. There got to be other components to how you're implementing a new technology to be mindful of. All right, Mark, thank you for getting unfiltered with us. We're going to be back to talk about extra uses with the lasers.
I can't wait.
Click like, comment, all the things that we have to do to help share and generate the algorithm so more people jump on and learn.
And find me at McCawley.com too. Go to McCawley.com. That's where you're going to find we've actually got a lot of data on the lasers, what you can do there. We've written several books and things like that. Some of them more perio specific, some of them more for patients, but it's good it's kind of a good resource, I guess, to start the journey. And then from there, the sky's the limit, man. You can really go deep into treating perio, and that's kind of where I'm living. So
awesome. Bug Mark, guys. Thank you so much.